Hello there, my name is James Jackson. I'm a reader in psychology at Leeds Trinity University, and I'm recording this session today to look at what tinnitus patients actually want, which is very different from what they actually get. Now, I'm based in the UK, north of England, so for that reason this is going to take on a UK point of view, but I think a lot of lessons can be transferred to wherever you might be. Now, you will find, generally speaking, that if someone with tinnitus goes to see their doctor, their general practitioner in the UK, they may find themselves, if they talk about their tinnitus, being referred to ENT, ear, nose and throat, and or audiology for, is there a reason behind why you have tinnitus? Is there a tumour in the ear? Is there some other condition? Is there earwax? Is there a reason for it? And then they may get referred onwards to an audiologist for possible hearing loss, etc. And maybe further down the line, specific appointments to talk about their tinnitus. Now, in some NHS trusts, if they're quite quick, you might go from GP to tinnitus appointment, could be as little as 3 months. But in some cases, it could be 9 months to a year. It's very much of a lottery based on where you are in the UK, but we'll bear that in mind as we go through the rest of this talk. Now, I'm a psychologist. I researched tinnitus, but to cut a long story short, I caught measles as a child, which resulted in a running problem with my hearing, leading to a bilateral catastrophic hearing loss when I was about 18 years of age. That resulted in the loss of about 85 to 90 decibels in each ear. I wear hearing aids, and I've had tinnitus for as long as I remember. So when I had an opportunity to stay on and do a PhD in psychology, that I very much wanted to pick tinnitus because it was something I was definitely struggling with at the time. Now, if you want to intervene to help someone with tinnitus, there's the realization that tinnitus is extremely common. In the UK, we may be looking at 1 in 7 people, 7 million plus people, 1 in every 30 children, 8% of the working population, the military, musicians, noisy environments, and maybe about 15% of people who've retired. But it's very common, it's out there, and strangely, there's little funding and there are few treatments. And the treatments that exist, generally speaking, are about helping people to cope with the condition, and there isn't really anything out there reliably for all people that could help to cure it. There are a few interesting avenues, and I think some of the people will be talking about that in the rest of these sessions, but for now we're looking at helping people to cope. Now, if we go back as far as 1984, I find it's interesting to note the difference between tinnitus as an internally generated noise, basically as a result of a damaged ear, and an external sound. So Warren Meikle was one of a number of people looking at it back in the 80s, this idea of trying to replicate a noise by playing tones outside the body. Is your tinnitus louder than this? Is it louder than that? Does it sound a bit like this one? And found that 90% of people indicated that their tinnitus was very quiet, tiny noise. When we know in occupational psychology, then sounds need to be about 70 to 80 decibels in an office before it really starts to interfere with concentration. But tinnitus affects concentration, so sum things up. But what was interesting is that this research group also asked people on a scale of 1 to 10, how distressing is it? So we find 57% of people described it as severe, another third moderately distressing. So just because it sounds a bit like a quiet external noise, it's an internal noise over which we lack control. It is much more distressing. Distressing to the point that about 50% of people with tinnitus can be assumed to have at least one other psychological condition, whether it's clinical depression, clinical anxiety, insomnia and sleep difficulties, or perhaps some combination of those three. And at the moment, even if you go back to that classic paper from them, the late David Bagley and various other names in the field, then we find that there isn't a cure for tinnitus. Lots of people have it. Why is this? There's a couple of reasons. First of all, there isn't really an ability to have an objective outside marker of what somebody is feeling with regard to their tinnitus, being able to tell it's there. And at the same time, a lot of people have tinnitus with a lot of different causes. So can they all be treated in the same way? A lot of complexity. And as soon as you get anywhere into the tinnitus field, it gets quite complicated quite quickly. But there are significant challenges to research. Based on some of my research that's upcoming and in preparation, then I asked 358 people who specifically in the UK went to see their doctor, their general practitioner, about their tinnitus. How satisfied were they with that initial appointment? So we have these scores, each statement on the left-hand side. The one at the top, the first healthcare professional I saw was honest but positive. So you find out who strongly disagreed, were neutral, or agreed or strongly agreed. So if we take everyone who agree or strongly agree with that statement, and we look at some of these, we find satisfaction is about 40%. So the practitioner was honest but positive. They listened to me. They treated me as an individual. I was satisfied about 40%, which means if you want to keep to this strict criteria, 60% was not satisfied. Now, if we look at some of these, perhaps is more interested to the audiologists who are here today or listening to this later, being referred to secondary diagnostic services, i.e. audiology, without having to fight for it, it's about 47%. So, not everybody will seek help. Of those that seek help from their GP, a little less than half will move on to the next stage and see people. Arguably speaking, it could be more, or it should be more, but it's better than I feared, if I'm honest. This other one, did the healthcare professional discuss distress and helpful strategies? This is lower, so 25% of people agreed with that statement. That means that 75% of people who saw their GP about tinnitus did not discuss tinnitus distress and did not discuss helpful strategies. As a psychologist, knowing currently that the main tool in the box are psychological interventions such as CBT, acceptance, ACT, mindfulness, things like that, this really disappointed to find that with this one, 8% of people were referred on to a psychologist later. I think this is worrying for the simple reason that I like to talk about tinnitus as being like a bereavement. There's that sense of having to accept that your life before tinnitus has ended, and you have to accept that in order to move on, and it's very much of a challenge. Personally, it took me many years, and I'm happy to say I have a flirtation with alcoholism in order to get through that. And for only 8% to see a psychologist or some for psychological therapy, to my mind, it is very much a weak spot. Now, we took these people and I interviewed 10 of them in order to actually see where are these scores coming from. So 10 qualitative interviews and about 8 hours of interview content, and came up with a few themes. So one of them, taken from one of the crows, it's like suffering silently, but it's not silent. A sense of you being on your own and struggling. So participants reported that the tinnitus had real noticeable effects on their physical and their mental health and their well-being. And again, this sense of bereavement, with that sort of having to accept things, is a real difference in how people consider their life before and after realizing that they had the condition. And probably the most problematic aspect of it is that when they spoke with healthcare professionals, there was a sense it was all about the diagnosis. Why do you have tinnitus? Do you have a hearing loss? Is there an issue with the ear? We need you to have a scan in this one ear because there might be a tumour or other complicated causes that we need to get to. And of actually having tinnitus and dealing with that is pushed off to one side, which is not what a tinnitus patient wants. So breaking the themes down a little more is the clear sense that this focus on why you have tinnitus is seen as being quite distressing. The idea that healthcare attention is all about this why, and that the person you're seeing does not understand how it's making you feel and how distressed you are and how it's affecting your ability to live your life. All participants reported in quite intense feelings of anxiety, depression, suicidal ideation, all as a result of having tinnitus. So it's less about the cause, but more about wanting help and to be supported. So represented by comments such as, it feels sometimes like you've just reached the end of the line. There is nowhere to go to seek help for the tinnitus. Everybody's just interested in why you have it. So breaking down that theme again, management, self-management of tinnitus. It's interesting that over time, people will accept the condition. Could be years, it could be many years. But this acceptance of the condition help participants to control their negative thoughts, their fears about, oh, it's going to get worse, I won't be able to cope, my hearing will go, all these associated negative thoughts, and allow people to, perhaps, if not necessarily gaining control, but feel able to manage it. And what's telling and very disappointing is in every case of my interviewees, this was achieved through people learning about tinnitus themselves, seeking help, going online, not through what seems to be the limited advice that was given to them by healthcare professionals. So comments such as, I'm going to have to come to terms with the fact that these are my ears forever. So habituation is a personal journey, and we're not helping people. They're eventually helping themselves. The second theme, I got the impression this is no big deal. People with tinnitus absolutely need to be reassured at every step of the way that the condition is real, their feelings and their distress is real. And people were reported that the lack of recognition of this despair, of this distress, was really distressing. Now, a participant remembers a GP saying, your normal, suck it up. I don't think this is what the GP said, but it's certainly what the patient remembers and feels about that. Now, when we get to psychological concepts of support, people might think, oh, you can be socially supported, or you might not be socially supported. But there's a third. There's the concept of being unsupported. This is when you go to seek help and you don't get it, and you're dismissed. So people find themselves out in the street with the worst possible words ringing in their head, something along the lines of, there's no cure for that, you're just going to have to live with it. That's very damaging. As people work their way down the chain and they see ENT, audiology, etc., these comments come through and people feel that there is nowhere to go. So, one thing is for certain is that if you are a healthcare professional and you have tinnitus, there is a lot to gain from sharing the fact that you have tinnitus, and you are coming to this from a place of understanding. I don't recommend that you fib if you don't have it, but if you do have it, it means people think that you might be understanding how they feel. Because what patients with tinnitus need above all is empathy. Now, I'll talk a little bit at the end about this again in some more detail, but the difference between being sympathetic, meaning that you're pitying people, and being empathetic and that you're understanding people, are completely different things. And people with tinnitus do not see a lot of empathy in their journey through the primary care pathway. So this need is here, and you find there's no treatment plan. There may well be, let's see if you're hearing, let's give you some hearing aid, let's give you some sound therapy, let's look to see whether there's ways we can enrich the world around you and you have other things to listen to. But there's nothing about helping people cope and accept their feelings and the condition itself, which means people withdraw quite clearly from healthcare professionals and are no longer interested in anything that they have to say. So a 5-year battle just to get information. But this other one was interesting. She was so kind and compassionate. You get through anything if you meet a person who understands you. This is someone who didn't really know where to go, but they went through Tinnitus UK to a self-help group, and the person speaking there was a hearing therapist in the UK. You don't see many of them now, but they used to be more of a thing. And she saw the woman at the end, how can I see you? Went back to the GP, explained that this woman exists, got a referral, saw her for 1 hour, and described this lady as being empathy and understanding itself. And just having the hour to talk things through meant that my participant reported that they didn't have to see anybody else about their tinnitus for 3.5 years before it felt necessary to talk to somebody again. So empathy and understanding can go a long way. So clinical aims is you must avoid telling people that nothing can be done. It's so damaging. But otherwise, it's about reducing distress and aiding habituation, which will happen to most people eventually, usually under their own power, rather than being helped by researchers and healthcare professionals. So we can do more. In the UK with the NHS, we have things called NICE guidelines. Now, I've got to remember, I believe that's the National something for Clinical Excellence. It's about working out what's an effective treatment and cost effective. What do we do first? And since 2020, the NHS have been recognising that psychological therapies are an effective, cost effective, and should be provided treatment for people with tinnitus. So it can be, digital online CBT provided by psychologists, or group-based interventions using mindfulness and acceptance commitment therapy, CBT, whether it's group, whether it's individual. Online can be just as effective if you have captions and no issues with hearing. But a lot of psychologists aren't available. So in the UK, we have this issue when audiologists may find that their job is expanding rapidly into counselling. So there are gaps between willingness to do so, training, confidence, competence, and there aren't really any courses out there that are properly accredited by the right professional bodies. Though I'm looking to change that. But it means psychoeducation for tinnitus is key. People need to be given information as early as possible. And they need to explain the processes which lead to tinnitus, what coping strategies are, why some work more than others for different people at different times. That's a whole discipline in itself. And importantly, that it takes months for people to be told this before you start to see behaviour changes and people acting on that. So when you've got the doctor, ENT, somebody about tinnitus, months, the earlier people get access to education and information, and the better they understand it, the more purposeful the meetings, the later appointments become. So you have tinnitus treatment pathways, there's delays, and treatment will take some time. But what is also interesting, if people are in a waiting list for an appointment, you actually start to see a reduction in tinnitus distress, whether it's an increased awareness, coping skills, being a bit less worried because you feel you might get answers, even though you may not. Let's not forget, I've had participants in that study being told things like, oh, if only you were deaf, I could have helped you. And that's not something that you want to say when someone's then left outside alone struggling with their tinnitus. But a sense of, if not habituating, that awareness and understanding that can lead to an improvement. Which is why I'm personally a big believer in mindfulness as one of several examples of psychological intervention. An article and a research paper that I've published recently about mindfulness. But you find that this is about living in the present, and this talk isn't about mindfulness, but people who are spending more time worrying about the future than observing what's happening in the present. Worry, anxiety is a future-orientated emotion. Catastrophizing, rumination, they're about, it's bad now, it'll be worse tomorrow, I won't cope, my life won't be worth living. And this fearing of the future leads to ineffective coping strategies that don't help, and as a trait leads to poor mental health and well-being. If you can improve people's mindfulness through practice, you start to see more positive appraisals and working toward the acceptance of the condition. And people who do get mindfulness do see, but they do tend to provide anecdotal feedback, which I don't ask for, but they go, oh, that was really helpful, I'm very grateful for this. And once you teach people how to be more mindful, even if it's just with regard to their tinnitus, it leaches into all other areas of people's lives. So it's one type of intervention which can be very beneficial, but you also need the education at the start for expectations and for people to understand why you're doing what you're doing. So it means when people are waiting for appointments, there are ways of delivering things online that could be using that time that is otherwise wasted. So there are many self-help resources available, some of which are evidence-based. And what is definitely true is that while you can just make something up that looks like an intervention that might not work, you find that if you know what you're doing and you guide people scaffolding through things bit by bit, it's much more valuable than people just going to Google and typing stuff in. It helps to build up a foundation and a skill set. So I have 8 podcasts really, taking people through basic body scans of mindfulness, going through to, well, let's say intermediate things, nothing advanced there. There's all actually relatively open source, but put them in a podcast, visual imagery, captions, music in the background, and people watch these 4 times a week for 8 weeks, getting a new one every week. And you can see a clinically significant improvement in 1/3 of people in about 2 months, shown in the paper. So if people are waiting for appointment, there are things they can do. Now, I've worked in the past with Tinibot, which by hearing power, Tinibot now known as MindEar, but I know there are other smartphone apps where people will be talking about those. I'm only mentioning this one through personal experience, and while I've worked with them, did a grant together, I'm not paid by them, I'm not part of the company or anything, but to give an example, in that we were working on $50,000 Australian grant in order to work together and look at the effectiveness of smartphone applications. This one, again, there are others. And the work that we've done has allowed it to step forward, so it's now referred to as MindEar. And you might see more about that in another talk. But these are all Tinibot pictures, a chatbot bit, education, some internet-based CBT, goal setting, some sound therapy things you could use, and mindful exercises that I originally provided that can be used. Some of it behind descriptions, some of it isn't, but apps like this one, not only this one, apps like this one can be a gateway to understanding and education that allow people to seek out things that they approve of. So, in terms of conclusions, we would never, ever, under any circumstances, tell someone with tinnitus that it's incurable and that they'll just have to live with it. There is value in empathy training workshops in order to allow people to say the right things and promote and illustrate their understanding of a tinnitus patient rather than just pitying them. And be aware that basic tinnitus information takes time. to take. So you've got to think about where in the process do people get information and referral advice, where are they going to go eventually, so that when they work down the pipeline, they're mentally prepped for what comes next and have learned a few things about the condition before they discuss the condition. Because ultimately, people will find their own information online and they will habituate. But as in my case, it took a decade. It could easily take more. So a few quick words at the start, correct, supportive, empathetic conversations could cut this down by years. So for anybody that works with someone with tinnitus, you need to know what online resources are out there that people could make use of between appointments. And you need to know your facts. So you need to know what has an evidence base. You don't need to do it. You don't need to give people cognitive behavioural therapy without 3 years of training, and you really do need to be trained, because 10% of CBT actually has negative effects, so you need to be very careful with these things. They can't be dispensed by people who've done a bit. It can get quite dangerous. But you need to know who you can refer people to, or you can say, but actually I understand that this can be quite effective. Why don't you try that? So don't keep people when you can refer them on to someone who might have a better chance. Otherwise, when it comes to concluding the game, knowing your skill set, I got ahead of myself, is a professional aim. Know what you can do, what you can't do, and be aware that if you reach the limits of your knowledge, referring somebody on is the right thing to do. It's professional and it's good practice. So, otherwise, like I say, empathy is key. Even if you just have an empathetic conversation and allow people to explain how they feel, and for you to approach that with understanding, that alone can be hugely beneficial. Let alone all the interventions and stuff come later, because that's what people want. People with tinnitus want to be understood. They want to be talked to about their tinnitus, not necessarily what causes it, which the medical profession will run off to, but that they have tinnitus. How did it make them feel? Tell them that you understand that, why they feel that way, and you're able to provide some information and some evidence-based help. So hopefully it's less than half an hour. Thank you very much for your time. My email is there if anybody wants to get in touch. Otherwise, take good care and thank you for listening.